Good day, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health here in the United States. It's my pleasure to welcome you to this edition of our Hep Test webinar series, where we'll be exploring linkages to hepatitis testing and care for persons experiencing homelessness in 3 countries. Greatly appreciate your interest in how we can extend services for this marginalized population. This edition is a part of the Hep Test webinar series that we have been supporting and convening since September of 2020, where we look on a variety of different testing strategies for key populations around the world for both hepatitis that's necessary to achieve goals for hepatitis B and hepatitis C elimination. As you'll see here over the next 90 minutes, we really seek to focus on hearing from persons in the field, sharing their experiences and lessons learned of how to deliver these critical testing services to these populations at highest risk for hepatitis B and hepatitis C. One of the guiding principles of disease elimination is that you can only eliminate diseases through achieving health equity. And that's why we're focusing on this population today. Next slide. Persons who are homeless have multiple health issues, but one of them is hepatitis C, where one recent meta-analysis estimated that there's over 60% greater risk of having hepatitis C among persons experiencing homelessness. And that, again, is why we are looking at that population today and trying and seeking to hear from programs delivering hepatitis testing and treatment services to learn more about how to reach these populations. On the call today, on the webinar today, you'll be able to submit questions to the panelists through the Q&A function here on Zoom. Encourage you to submit your comments on chat. I'll be asking the presenters after their presentations to seek to respond to the questions in the Q&A that are related to their presentations. And we look forward to having a panel discussion following the presentations to touch on those questions and comments. These are the speakers you'll be hearing from today. So let me introduce Bernadette Lettner, who is a treatment nurse currently with the Toronto Community Hepatitis C program, who has more than 12 years of clinical experience and currently supporting treatment and care of persons living with hepatitis C who use drugs and alcohol, including persons who are homeless. You'll also hear from Doug Belanger, who's a community health worker with the Toronto Community Hep C program. He also has lived experience with hepatitis C and has a lot of experience in working with populations at risk for hepatitis C. So let me turn it over to Bernadette and to Doug. Welcome.
I think you'll just want to unmute you.
Great, thanks so much, Lindsay.
Thank you.
So yeah, if we can just jump right onto the second slide there. So the first thing I just want to touch base on is oftentimes we end up thinking of people experiencing houselessness or people who are homeless as not actually having a community of care associated with them. So I just want to challenge that. We've often heard of the saying, home is where the heart is, and I think that we have to look at people and folks experiencing houselessness as embedded in communities and embedded in communities of care, and how do we engage folks within that community. Next slide. So Doug's going to tell you a little bit about the Toronto Community Hep C program and the work that we do.
Toronto Community Hep C program has been around since 2006. We are connected with 4 other health centers here in Toronto. The ideal is to make up Hep C testing and care accessible to anyone. We believe that everyone can successfully cure their Hep C.
We'll jump on to the next slide. And a bit of an overview of how we do that work.
We have CSWs, who are people who have gone through the treatment with us, and they have gone on to complete peer training program and have been hired to work in this field. We also have a continuing care group, a way for people to stay connected and accessing supports one-on-one. We also have a patient advisory board, a group made up of people with lived experience of Hep C and treatment who advise and direct programming. Sometimes people choose not to be participant in groups, and sometimes, like with incarceration and geographic distance, they are unable to. So we will offer one-on-one support tailored to the individual.
We'll jump on to the next slide. So a couple of things ended up changing recently around how we offer services as a treatment group, and one of the first things I just want to touch base on was the COVID shuffle, as we like to call it. So there was dangerous overcrowding in shelters in downtown Toronto that led to high rates of COVID infection and some deaths. And so as a result of that, they ended up deciding to move people from downtown shelters into hotels that were vacant at the time. And that really had a result of displacing people from the community and connections that they had previously been able to access. So very early on, we decided that outreach to those hotels was something that was really important for us to do. So to be able to offer testing and treatment in hotels where people were being sheltered. Now, after kind of the waves of COVID happened, those hotels were closed, which led to people trying to re-access shelter systems downtown, but the capacity of shelter systems didn't increase in order to be able to allow people to come back into shelters. So what happened is people started moving into parks, and so now there are a lot more encampments in downtown Toronto, and as a result, as the summer comes up, encampment clearings have increased once again. So people's homes are being removed from the parks in which they set up. So what this has created is a much less stable geographic area for people experiencing homelessness to stay and base themselves out of. Next slide. Another big thing that's happened is this digital divide. So while I'm sure I certainly have had more medical appointments virtually over the last couple of years than ever before in my life, for people who have phones and computers, web digital access, that's great. For people who don't have them, then that means there's virtually no access. So what we ended up doing is providing devices, both phones and tablets, to individuals to help. We noticed that sometimes even providing devices wasn't enough, so we started to create touchdown spaces for people to connect on computers. And we've also developed this idea of doing online accompaniments. So instead of accompanying people to a location for their medical visits, we now do online accompaniment and work through tech challenges with individuals in that way. Also provide a space where people can end up answering and asking questions about those appointments. Next one. And as John ended up alluding to, part of the reason that this work is so important is the equity piece that's part of this. So life expectancy for people experiencing houselessness in Toronto is significantly lower than the general population. We know that people have complex health needs, but they also have very high engagement in care. So we need to end up looking at how we respond to people experiencing houselessness as a population and not just use general guidelines to end up addressing the unique needs of people experiencing houselessness. So an example of this, when we were looking at rolling out COVID vaccinations in Ontario, it was by age demographic. So people 80 plus, and then 75 plus, and then 70 plus. Now, if we use that same rubric in order to look at vaccination for people experiencing homelessness, we'd never get to the place where people are being vaccinated if life expectancy is 42 years instead of 85. So what we were able to do in conjunction with an infectious disease team at a local hospital was provide COVID vaccinations to people living in congregate settings. In the initial wave of vaccinations, we had really high uptake, 80 to 90% of folks were vaccinated, and that decreased outbreaks in congregate settings. So when we're talking about hepatitis C and hepatitis B, it often means that people experiencing houselessness have more advanced liver disease at a younger age. So screening and comprehensive healthcare are an important part of how we do equity-based healthcare and health interventions for priority populations. Next slide.
Engaging
So how do we do this? Go ahead.
Engaging in community, using people with lived experience in all levels of our organization.
So from frontline workers to management, people with lived experience of injection drug use, of houselessness are employed throughout. And then when we're engaging in community,
we leverage the connections.
Yeah, we take a look at people who are community champions. So who do we know in the community who's a leader, and how can we end up using their connections to community to be able to engage in specific needs that that community expresses? We leverage connections. So everybody's connected, right? Oftentimes we end up getting referrals from folks who say, like, this person didn't show up, they were a no-show, and that's the end of it. We can't go any further with this referral. So oftentimes when we engage with people, we talk about consent early and often. If you don't show up next week, can I end up calling your local pharmacy? Can I talk to the person at the drop-in who's your worker? Can I give a call to your parents that you end up checking in with once a week? That kind of thing. So we support the relationships that already exist. If somebody does go to a local pharmacy, that's where we're going to end up doing their Hep C treatment, right? So making sure that we're building on the community connections that already exist.
Consistent, same time, same place for 17 years.
You know where to find us.
Yeah.
And part of this work is also very bidirectional. So we're constantly learning and evolving. We work on our communication on a regular basis with folks. And part of the reason that we're able to do this work is because Ontario ended up committing funding to hepatitis C treatment teams, and that funding has been consistent for the last 17 years. Next slide. So what are some of the approaches that we end up using?
Test and treat anywhere, and
yeah, so we treat people when they're ready. If somebody tells us we're ready, then we're going to end up working on being able to support them in treatment. So sometimes people have like ideas of what somebody needs in order to be able to engage in treatment in a successful way. I got to tell you, I've been proved wrong more times than I've been proved right. If I think that there's something in the way of somebody accessing treatment and they tell me they're ready, they're right. They're absolutely right.
Immediate contact, getting phone numbers, publicly available.
Yeah, so all of our phone numbers are available. So Doug has a work cell, I have a work cell, people know how to contact us. And we're constantly visible in the community.
Planful care, anticipate, communicate, and eliminate.
Yep. So often one of the questions we ask when people are first connecting with us is, do you have any outstanding warrants? Not because I'm nosy, but if you end up being picked up and brought inside, I want to make sure that we're in touch with the corrections institution and we're able to end up transferring your medication with you. So we anticipate needs that people are going to run into. We communicate what those plans are. And we also end up working at connecting individual circle of care. So we're not just looking at one individual and treatment for that one individual. We're looking at how we can end up using that individual as a contact to a wider community. So part of how we do this, we did some pretty intensive postal code mapping at one point in time. We were looking at the referrals that we received for people who didn't actually make it down into our center. And what postal code were they at? How could we end up finding them? And then we would develop testing and treatment strategies in the community so that we could go directly to those locations and work in partnership with people in the community to chase prevalence and find people in the right place at the right time. Next slide. So some of the components of what this work looks like.
Is housing support.
So it's very needs-based, right? So if somebody comes to Doug and says, hey, I need a tent,
I will get it for them.
You'll find a tent. Part of the work that we do is looking at co-location, and partnerships are really key on this. So we go to places where people are accessing services. There's a community barbecue, we're sitting outside.
Yeah, and then we have referrals.
constantly working on referrals both in and out, and those ongoing connections. So part of the way that we end up maintaining connections is through our continuing care groups, where people who following cure can end up accessing an ongoing support group. We do peer training, we do research engagement on a regular basis, and we have our participant advisory board. So next slide. Some of the things that supports this work, I know that we're lucky in the context that we currently have. Our public health laboratories have done reflex testing for us. So if somebody is first-time antibody positive or they have no viral load on record, they will automatically reflex an antibody test to viral load. They've simplified what our testing is, so it's just a single serum tube that we end up needing. And we can also end up using dried blood spot testing for folks. With point of care testing, we use a 5-minute read rule. So if an antibody test is positive at 5 minutes, we go directly on to confirmatory testing. And we've been able to expand testing by training people with lived experience to provide hepatitis C testing in connection to care. All of this work couldn't happen without integration. So we're integrated within supervised consumption services, within harm reduction distribution services, within pharmacies that end up having high numbers of people who end up accessing services for methadone, Suboxone scripts, or opiate safer supply programming. Next slide. And then a little bit about the work that we're about to do. So we've got this idea that we can end up achieving Hep C elimination in Toronto, and in East Toronto is kind of like a little microcosm of our world. So the first project, next slide, that we're looking on is emergency department opt-out testing. So this is actually a slogan, and one of the members of our Hep C treatment team that came up with this. So we're looking at launching this in June. There is a hospital in East Toronto that connects with about 25% of the population on an annual basis, and of those, about 60% have blood work drawn when they're in the emergency departments. So what we're going to end up being able to offer is opt-out testing for everybody who ends up having blood work done already in the emergency department. And through a partnership with the hospital and the Toronto Community Hep C program, we'll ensure people are referred directly for treatment from there, because we know people experiencing homelessness and people who inject drugs are routinely not referred to hepatitis C care. We'll see hepatitis C on the problem list, but no follow-up referral to treatment. So risk-based testing is notoriously bad at identifying and appropriately stratifying risk, especially in an emergency department setting. Additionally, there's a vested interest in people avoiding stigma and discrimination in episodic care encounters, and so they don't disclose risks for hepatitis C. So one way to combat that stigma is to offer universal testing to everybody, ensuring people are identified and provided with high-quality responsive care in a single access pathway. Next.
Point of care testing, comprehensive training program for community organizations that want to operate CV antibody testing. Service users they are connected to, navigators with lived experience connecting to each of the sites and supporting testing and connection to care and offer treatment navigation.
So we were really lucky in being able to receive one-time funding to buy a whack of point-of-care antibody tests. And we decided that we would do like a training blitz. And so people who are interested in being able to create testing sites throughout East Toronto are going to be able to do that and link us directly to care. Next slide. And the last one we'll talk about quickly is called the One Drop, One Stop. So this is going to be a finger stick testing and immediate treatment start with RN-led treatment starts for folks in a supervised injection service. So finger stick for hepatitis C antibody viral load, also HIV and HBV, and then we'll be able to do a fibrosis assessment as well using an APRI. So we'll do liver enzymes and CBC on individuals. So what are some of the ways that end up allowing this work to be done? Next slide, 2 big things.
Community and consistency.
So making sure that there's an ongoing commitment to community building, being aware of what's happening in community and being able to change your services to respond to that, supporting people in what's impactful in their lives, and being consistent, being there for people, continual open doors.
Yeah, and always have the connection.
So we'll end there with thanks for letting us talk a little bit about how we do this work and what drives us.
Thank you.
Thank you so much to both of you. That's just a really fantastic program, and you explained it so well. To emphasize, as you noted on your last slide, the importance of community involvement, government support, and learning by doing and being open to change as you learn from your community. And I'm sure that over that 17 years, that community has changed a great deal, and your strategies have had to change along with it. And so look forward to learning more about your program. And so thank you again. Now let's turn to Dr. Mandana Khalili, who's a professor of medicine at the University of California, San Francisco. She's chief of clinical hepatology and director of clinical and translational research in hepatology at UCSF and San Francisco General Hospital. And she co-directs the UCSF T32 training in hepatology. And she's focused a great deal of her work on addressing health disparities related to hepatitis B and hepatitis C. And that's why she's here today to talk about hepatitis C and the homeless in the San Francisco area. Mandana?
Thank you, John, for that kind introduction. And I'd like to thank the organizers for their invitation to present at this very important forum. I am going to share my screen with you. Hopefully we can make this happen. There we go. Is it, sorry, doesn't look like, oh, there we go. It's a portion that's presenting, huh?
Yes, yes, that's what we're saying. Lindsay, do you want to go to our version?
Or just 1 second.
Just if that's okay.
Thank you very much. I really appreciate it. Yes.
Yeah. See if we can get that corrected quickly.
Thank you. Hey, great. Thank you again. Okay, so if you don't mind, next slide, please. Great. Okay, as it's been mentioned already earlier, that individuals experiencing homelessness and marginally housed individuals have high prevalence of hepatitis C infection compared to the general population. And this has been documented at about 10 to 50% in the United States, but in San Francisco specifically, where I reside, the prevalence of hepatitis C is estimated on the higher end of that range at 46%. The primary risk factors here include injection drug use, there's history of incarceration, mental illness, and also other type of barriers and complications that limit access to healthcare system. Treatment initiation is also low due to many barriers, but studies show that racial ethnic minorities, those with substance use problems, Medicaid insurance, access issues are least likely to initiate treatment, and we know that this is exacerbated in the setting of homelessness. And the data on these barriers are more limited. To improve HCV in care in the homeless shelters, there's therefore a need for targeted education programs. There's point of care testing, treatment, and identifying potential barriers to successful implementation of HCV care models. And so we embarked on our journey here. Next slide. We then I have addressed these issues across a spectrum of healthcare services. In addition to San Francisco, we engaged in partnership with a group of investigators that were interested in enhancing hepatitis C screening and treatment among individuals experiencing homelessness in another U.S. region. This was Hennepin Healthcare System in Minneapolis, Minnesota. We also engaged our local community efforts, including the San Francisco's End Hep C campaign, which is the multi-sector collective impact initiative that uses evidence-based practices, community wisdoms, and leverages already existing resources to eliminate hepatitis C within within the San Francisco Bay Area. And we wanted to make sure that these processes that are being implemented are applicable to geographically diverse regions and populations, and within the communities that efforts that already are existing. So we tried to better understand the perspectives of stakeholders to ensure that hepatitis C testing and treatment processes that we wanted to implement within the context of persons experiencing homelessness are feasible, that they met the needs of those individuals, and that they could be scalable. So we did this by first conducting focus groups with individuals accessing homeless shelters and evaluated their barriers and facilitators to hepatitis C care. We then did a comprehensive assessment of potential factors that could influence the integration of hepatitis C services in the homeless shelters themselves. And we use all of this information to design an effective universal Hep C rapid testing and linkage to care model in hepatitis C shelters. And I'll share this data with you next. Next slide. To evaluate our shelter client perspectives, we did 2 focus groups involving 10 women and 10 men accessing large homeless shelters within the San Francisco area. This focus group was a semi-structured interview format. We asked about individual program systems, so societal level barriers, and facilitators to implementing universal hepatitis C testing and linkage to care. Next slide. We identified some key barriers to hepatitis C testing and treatment at the individual level. These included limited knowledge and misconceptions about hepatitis C infection, mistrust of the healthcare system, comorbid conditions that existed, such as substance use, psychiatric, chronic medical conditions. Some system-level barriers included limited advocacy for HCV services by shelter staff. Individuals highlighted some societal level barriers, including stigma that exists surrounding homelessness, and individual system and societal facilitators that we identified from the participants included internal motivation to address hepatitis C treatment, financial incentives to engage in hepatitis C care, having had prior experiences with rapid HCV testing, and also availability of affordable treatment for hepatitis C. But most importantly, we found that there was an overwhelming support from shelter clients about receipt of HCV treatment if needed. Next slide, please. We then went ahead and did 4 focus groups with homeless shelter staff, practice providers, and social service outreach workers in San Francisco, California, as well as Minneapolis, Minnesota. We asked for their perspective towards establishing this universal testing and treatment within the context of the shelters, and asked the same type of questions, key barriers and facilitators from these individuals. We found that despite many barriers that were listed, that there was, again, an overwhelming broad support from these stakeholders for integration of hepatitis C services within the shelter setting across the 2 cities. Next slide, please. So let's talk a little bit about some of these barriers and facilitators that we identified. With respect to the societal level barriers, the stakeholders, now these are not individuals who are accessing the shelters, rather the shelter leadership, along with providers and other individuals engaged, included the issue of insurance, high out-of-pocket expenses, restrictions of access to Hep C treatment due to active drug use or alcohol use, excessive paperwork that was required for hepatitis C authorization forms from the payers. From a system level perspective, there was workforce constraints and limited healthcare infrastructure. There was mention of hepatitis C stigma and low knowledge of HCV treatment among the staff, and existing shelter policies that may prevent potentially implementation of these processes within the shelters. At an individual level, there were mention of client barriers such as competing priorities, the behavioral health concerns, there were health attitudes, but also some important facilitators that we identified was that there were high acceptability and buy-in for this process. And that we also identified linkage with social service providers as being critically important. Next slide, please. So what were some of the recommendations that were brought forth to us? We received these following recommendations. Offer the shortest possible course of hepatitis C treatment, establish a designated hepatitis C coordinator to really address the needs of the clients in a holistic way, use incentives to engage the patients, provide extended shelter stay during the treatment so that there won't be disruptions of housing and stability at those times, educate shelter staff, offer peer navigation and support, and importantly, provide formal hepatitis C education to shelter clients to enhance their engagement. Next slide, please. To summarize, we learned the importance of enhancing knowledge of hepatitis C, harm reduction among shelter clients. We identified various barriers to address, and we learned that providers and shelter clients agreed that patients experiencing homelessness are concerned about their health, and that scaling up hepatitis C services was important in the homeless shelters themselves. So we focused on formatting a multi-agency partnership, for example, partnering with the Department of Public Health in San Francisco to get point-of-care testing, as well as the, as mentioned earlier, community efforts, including the Hepatitis C-Free campaign in San Francisco. We partnered with existing services, health services for the persons experiencing homelessness, including street medicine teams, and in this city and in Minnesota with the shelter clinic and providers. We also identified co-localization of hepatitis C services within the shelter and implemented a formal patient education to improve client knowledge. So this led to the following model of care in two different settings, as mentioned, San Francisco and Minneapolis, among 4 large homeless shelters where we provided shelter-based point-of-care testing for hepatitis C by either shelter medical staff or street medicine team. Those who were negative were given information on hepatitis C and its mode of transmission, and those who tested positive by point-of-care testing had a confirmatory Hep C RNA testing, and then underwent a standardized 30-minute Hep C education program. This in-person comprehensive education program was delivered by a designated Hep C nurse or a pharmacist or an advanced practice provider within the context of the shelter. The standard of care HCV therapy was offered to all participants with detection of HCV RNA through insurance or patient assistance programs for HCV by prescribing provider. We had the treatment primarily delivered on site at the shelter or through coordination with the primary care providers or liver specialty providers, if such patients chose to or were engaged through specialty care or addiction services. And the treatment plan was made at the discretion of the treating provider and in accordance with what the insurance allowed. The medication dispensation, because of this, varied, and it ranged from either direct observed therapy, for example, within addiction services, to weekly or monthly dispensing within the shelter themselves. If needed, the study team assisted participants in obtaining insurance and also facilitated linkage to primary care services. So in San Francisco, we had a designated Hep C registered nurse coordinator that was actually a member of the street medicine team to begin with. And we did this strategically to ensure that there is sustainability of these efforts. She gained knowledge on treatment within the shelters in collaboration with the shelter providers and primary care providers, or the safety net liver specialty clinic if needed, where the cases may have been a little bit more complicated. In Minneapolis, a doctor of pharmacy that was embedded within the shelter clinics managed patients on treatment in collaboration with the shelter clinic staff. And Minneapolis Safety Net delivers specialty care was also available should linkages be needed. We followed the patients throughout the treatment, completed blood tests at the end of the treatment to document sustained virologic responses. And we obtained as much clinical information as possible and asked questions about patients' knowledge and risk factors, et cetera, to ensure that our efforts were effective. And we paid patients or individuals a $25 incentive to get tested for hepatitis C and $75 at the end of the education and also at the end of the completion of their hepatitis C treatment. Next slide. So from August 1st of 2018 to January 30th of 2021, we engaged all individuals who were willing to participate that were either treatment naive or had not received hepatitis C treatment within the prior 3 months. Our recruitment strategy was through advertisements of availability of testing and treatment within the shelter, as well as directly approaching clients. We approached about 1,199 shelter clients. Of these, 766 participated. A total of 120 individuals, 120 HCV testing sessions were conducted in overall 72 in San Francisco and 49 in Minneapolis. And of the 766 individuals who participated, 162, so 21% tested positive for hepatitis C antibody. Of these, 66% had detectable HCV RNA, so about 2/3 had active viremia. Overall, 2/3 of these individuals were male. About half were African-American, but HCV positive patients had a higher proportion of white population. We had 52% overall that have been tested for hepatitis C in the past, and nearly 80% among HCV positive patients. And again, this was due to a significant amount of effort that had been previously implemented within the city of San Francisco. And it's expected a higher proportion of hepatitis C patients used drugs in the past, and this was at about 2/3 compared to 13% of those who were HCV negative. Next slide. With respect to our education program, we did this through a group education of up to 10 participants. If needed, we also provided individual education sessions, but predominantly it was performed through group education. The content of this education session was pretty comprehensive. We gave information about hepatitis C epidemiology, its transmission, its diagnosis, its natural history, the treatment options, all the information related to liver health, including vaccinations for hepatitis A and B, and resources for substance use disorder therapy were also provided, as well as syringe access services and linkage to liver disease care as needed. We made also every effort to make these education programs sort of tailored towards the perceived barriers and misconceptions that came up over and over again among the population. We found that our rate of acceptance of hepatitis C therapy significantly increased following education. It went from 71% to 86%. The confidence in methods to prevent hepatitis C transmission also increased. And overall, we noted that participants indicated that their effect of hepatitis C on their general health was significant, and that information or that percentage also increased. Next slide. So what are our results? Well, we were able to engage 62% of the patients who were eligible to receive hepatitis C treatment, which was, again, those who were viremic in treatment. We were able to achieve 82% cure rates in this difficult to reach population. And this is despite reported medication adherence that by providers were pretty low at about 50%, and by patients it was higher at about 88%. So there was some definitely evidence of lack of full medication adherence, but we were able to achieve such high sustained virologic response rates. The most prescribed treatments were, again, those that were allowed, and they were either 8 weeks or 12 weeks per the availability of the drugs through either government-based insurance or through patient assistance programs. Next slide. I wanted to highlight one additional important thing that is critical that we learned, actually. We tried to better understand the severity of liver disease among the patients who were hepatitis C positive and were accessing shelter services. And about 18% of the patients that we came across had evidence of cirrhosis. I want to highlight that we identified patients who had even decompensation of liver disease, and 3% of our patients had evidence of liver cancer, hepatocellular carcinoma. Another 17%, when we look through with other various means, such as serology, or if they've had a biopsy or imaging or any kind of hepatitis C evaluations in the past, having more advanced disease. So overall, I'd say about 46% of these individuals who were hepatitis C positive within our shelters had evidence of advanced scarring or fibrosis or cirrhosis, which really highlights the importance of engaging this population in hepatitis C treatment and the critical importance of focusing on this population for hepatitis C elimination efforts. Next slide. Okay, so I think our integrated model of on-site hepatitis C treatment, testing, and education, following extensive needs assessment, including stakeholder perspective, was successful in enhancing hepatitis C services and linkage to hepatitis C therapy. And our studies sort of demonstrated tailored models of care that reduce barriers to patient engagement, including co-localization of hepatitis C care within the shelters or supportive housing, and simplified steps to Hep C treatment are critical for hepatitis C elimination efforts in this vulnerable population. I will say that following our implementation of these processing, several other initiatives have certainly been implemented, including mobile hepatitis C treatment testing and treatment through mobile vans in San Francisco, ECHO implementation, which is a sort of distant engagement of a provider in order to ensure that we have expansion of treatment services and providers who are managing patients with hepatitis C as well. And also we have extensive engagement of primary care providers within the safety net services as well in addressing hepatitis C treatment. Next slide. Thank you again for this opportunity, and I'm happy to address questions.
Thank you again, Mandana. That's an excellent description of a very thoughtfully organized and implemented project. You know, it's particularly impressive, the percentage of persons who were experiencing homelessness that you were able to get on treatment, over 60%, whereas recent studies looking at commercial lab data suggested only a little over a third of persons being diagnosed with hepatitis C in the United States are receiving treatment within 1 year of that diagnosis. So just to put that success of that of your program in even more stark relief. So look forward to some questions and discussions here in a moment. But let's turn now to Dr. Elaine Soyman, who is the leader of clinical services at the Sediba Hope Medical Center in South Africa. Elaine is a physician. Her experience spans across various aspects of HIV and viral hepatitis management and clinical care. She's currently pursuing a Master of Public Health at Johns Hopkins, while leading clinical services at her nonprofit organization in South Africa. She does her work in collaboration with colleagues at the University of Cape Town. Elaine, we look forward to learning of your experiences. Thank you.
Thank you so much for the introduction, and thank you for the opportunity to share our work. So today I'll be sharing my experience in integrating hepatitis C services in a community-based setting, particularly amongst people who inject drugs, who comprise about 50% of our homeless population in the nation's capital. So you might be familiar with the global burden of disease, and especially also with the low case finding, even more so on the African continent. So I just quickly want to focus on our context in South Africa. So our local screening efforts have really been limited, also probably due to the level of care where treatment is being offered. And this is especially concerning in people who inject drugs, where we see a very high Hep C prevalence, about 55%. And some of the drivers of Hep C infection includes a high prevalence in both HIV and hepatitis C, with almost 15% HIV co-infection in those with Hep C. We also have high rates of risk-taking behavior in the PWID community, and then really limited access to both prevention and treatment services, which is further underpinned by low referral rates and persistent socioeconomic structural barriers. I just also want to sketch our picture in South Africa towards implementing Hep C interventions. So this has been a bit of a slow process since DAAs have been available. We've seen harm reduction services being scaled up in the country from 2016, predominantly through civil society. And we've had our national guidelines for hepatitis updated in 2019, with DAA formulations being registered in 2021 and a year later being launched on the market. So traditionally, we would treat hepatitis C at specialized hospital clinics, and patients would then have to attend multiple visits before treatment is initiated. But following a surveillance study we conducted at our organization among the community of PWID accessing services from our facility, we identified individuals who required treatment but failed to be initiated at the specialized units. So we decided to pilot a community-based simplified test and treat approach. This was in collaboration with the University of Cape Town and Doctors Without Borders, by really making diagnostics and treatment available at primary care level. For our pilot, community-based recruitment from the PWID community really leveraged the existing harm reduction interventions, and especially peer educators at our drop-in facilities to then trace patients who is known with chronic Hep C infection. But we also offered Hep C antibody screening at community hotspots at that stage during COVID-19 pandemic lockdowns, also at temporary shelters, and then walk-in patients. And for those who screened positive, we had same-day collection of blood for a qualitative PCR assessment and of viremia on site. So participants who were confirmed viremic were then further assessed for eligibility and initiated on DAAs and followed up again within these community structures. So this uptake cycle really resulted in a snowball effect where participants presented to our facility for screening or treatment as a result of word-of-mouth referrals. To cater for the large portion of homeless beneficiaries, our drop-in facility also offered showers, lockers, meals, safe spaces to collect with peers, and other biopsychosocial interventions. So just a brief overview of our simplified model. So we led with the rapid diagnostic testing for Hep C, but then also HIV and Hep B antigen. And those who were found to be co-infected were first stabilized on antiretroviral therapy or tenofovir-based therapy. We also offered Hep B vaccination if they tested negative for surface antigen. And if found to be pregnant or tuberculosis were diagnosed, DAA therapy would be deferred. So we then, after screening, conducted clinical assessments looking for signs of chronic liver disease, but especially for decompensation, and the decompensated clients would then be referred for further workup to the hospital level. Eligible participants who were found to be viremic were initiated on 12 weeks of sofosbuvir-daclatisvir, and we also supported adherence with directly observed therapy. So this was really individualized how frequently we would see the client, or it would be synchronized with other harm reduction services. Also peer support running throughout, stipends being given, or transport support depending on the individual's need. So in a high-risk setting like ours, it's really ideal to have the rapid diagnostics available. We made use of the OraSure technology, the antibody testing, which can also be used for self-testing. But interestingly, in our participants, the majority requested assisted testing by either the community health worker or peer educator. And we thought this was largely due to a large portion being first-time hepatitis C testers. So to give you a better overview of the demographics of our cohort, so of the 144 who were positive, who were assessed by the clinical team and had bloods done, 91% of those who had assessments were confirmed viremic. The majority were male, and with a mean age of 36, and 90% didn't know the hepatitis C or HIV statuses of their partners, whether injecting or sexual. The majority were also unsheltered or sheltered homeless. And then when looking at this Hep C cohort disease breakdown in terms of co-infection, we found 40% to have HIV co-infection, 4% Hep B co-infected, and 1% triple infected. So in our case, we used point-of-care molecular testing, a qualitative assay, which was the gene drive, to monitor our patient outcomes. We did it at 4 weeks end of treatment and 12 weeks post end of treatment. And I must say the point-of-care technology was really a game changer for us, where it enabled same-day or close to same-day initiations due to the results being available, and thus reducing the number of missed opportunities and also minimizing the difficulty of tracing a very transient population. So we also confirmed our SVR samples against a central laboratory, the Abbott real-time HCV, for the SVR confirmations. And we found the gene drive to have a high specificity and negative predictive value. So a significant practical issue that influenced our sample workflow was actually difficult venisections. And we had to make use of a dilution protocol to improve the performance of our assay with low volume or often hemolyzed samples. More recently, we've been using the GeneXpert quantitative PCR system on site, and particularly also the Hep C viral load fingerstick, which only requires 100 microliters of EDTA whole blood, and using the mini-vet as a collector for that. To highlight how this really enables quicker turnaround times, our viral load assessments were done within a mean of 7.4 hours, and this would be on days where there's high volume screenings happening, or co-infections also being present. And initiations would often be offered within a week, sometimes even within an hour, really just depending on the patient's follow-up plan in terms of their other harm reduction services, for example, weekly dotting of their methadone. So just to share some outcomes, final outcomes of our simplified treatment pilot for Hep C. So those eligible to be initiated, 92% commenced on soft DAC, and we achieved a per protocol SVR of 90%, noting that there was about 13% confirmed reinfections post SVR, but very few adverse events being reported, and all of them mild. Just want to share a quick word on reinfections. So in our setting, those who were suspected to have reinfections had the Hep C virus sequencing confirm it, so no resistant associated substitutions were observed. But in response, we really have to think about annual screening being offered, also knowing that retreatment is acceptable if patients are found to be reinfected, And then really optimizing harm reduction, which is not at scale at present, to be offered to reduce exposure to new Hep C infections. In our case, the majority of participants were either on OST or NSP, and we didn't find any statistical significantly different outcome, whether they are on one or the other, in terms of SVR, which was also encouraging for us. The key findings from our project revealed that the simplified point of service Hep C care model really yields acceptable SVR rates in our setting, but retention in care and follow-up remains both challenging and key to success. Our model also provides a basis for other programs in the region to utilize more community acceptable and cost-efficient approaches. And our successful implementation was really achieved through tailoring to the needs of our community and strategic collaborations. So I would just like to thank some of our collaborators, in particular MSF, the University of Cape Town, and then all the implementing partners supporting harm reduction services. Just to disclose. Thank you.
Thank you, Elaine. It's a really very interesting program. Really, as you were saying, the game-changing nature of having point-of-care testing available, and we look forward to exploring, that in particular, as well as some of the other aspects of your program. But let's turn now to our remaining speaker, Joshua Choi, who is the infectious disease and MAT care coordinator supervisor at the Los Angeles Christian Health Centers. He has been working on this for quite some time. He's a graduate of Johns Hopkins University, and we look forward to his sharing his experiences from the LA Christian Health Centers. Joshua?
Thank you so much. Let me just share my screen here. Let's see. Okay, it looks like there's a technical issue on my end. So Lindsay, would you be able to share the screen from here? Thank you so much. So I first wanted to explain kind of the role that I have, the infectious disease and MAT care coordinator supervisor. So basically what I do is I am a particular designated coordinator for HIV, HCV, and as well as in some cases syphilis, as well as a coordinator for patients undergoing MAT care. So today I'll talk about kind of our overall hepatitis C program, as well as something that we call focused care coordination, as well as the strategies that we've utilized in our screening and linkage. Next slide, please. And I have no particular disclosures. Next slide. And so when we talk about Hep C care in vulnerable populations, for us particularly, it's in the Skid Row community in Los Angeles. There are a few things that may come to mind, and I've listed a few here that are particularly important when we're talking about vulnerable populations. So the first is robust HCV screening, linkage, and treatment. The second is follow-up that is coordinated, consistent, and intentional. And finally, we have a rapport building and trauma-informed care that is crucial in order to engage well with these populations. Next slide, please. And so to provide a bit of an overview of our organization, again, we're the LA Christian Health Centers. We're an FQHC that is based in Los Angeles. We have two main clinics, one in Skid Row and another in East LA. We have 7 satellite clinics and 4 street medicine teams that are located throughout the greater LA area. And that amounts to around 13,000 patients cared for each year and around 70,000 medical visits. Next slide, please. And so within that is our hepatitis C program. And some of the specifications and characteristics of our program include universal HCV screening that is at all of our sites, including our brick and mortar and our street medicine sites as well. We have rapid HCV testing and field-based phlebotomy that is given right on those sites. We have low barrier access to HCV treatment, which includes primary care treatment. And we have coordinated follow-up that is engaged by the focus care coordinator. And all of these are providing care to a predominantly homeless population, unhoused people, and those who are in transitional housing or in shelters. Next slide, please. And so focus care coordination. What we mean by this is we have a dedicated hepatitis C care coordinator, which is myself, who works directly with our providers and uses a internal database that links with our electronic medical record in order to engage with patients real time. So what that looks like in our care cascade is we have antibody tests that automatically reflex to the RNA tests, and this is in brick and mortar settings. And the care coordinator receives real-time alerts of RNA positive tests that come in. And so the care coordinator meets with these patients, they educate them, and then they continue to outreach them, which includes writing letters, going to the street, home visits to see these patients. And then they continue to help these patients link to care. Next slide, please. And so in the street medicine setting, the role of the care coordinator is similar. So there is rapid point of care tests that are done, and those are received and given back to the patients in around 15 minutes or so. And we have confirmatory blood draws that are given right at that spot. So we have medical assistants and registered nurses that are doing those blood draws right after those positive antibody tests are seen. And the care coordinator meets with these patients and immediately schedules a follow-up appointment, gets necessary contact information, and meets with this patient. Then they continue to outreach to the patients as needed for follow-up, and they link these patients to care. And one thing I want to particularly note in this particular slide is that in each step of the process, there is incentives that are given to the patient. So for each patient that is coming in for a rapid test, we give them McDonald's sandwiches, we give them hygiene kits and snack bags in order to have them test. And from there, we have TAP cards. So that is for public transportation that we give them if they do a blood draw. And then once they come into their appointment, we have gift cards that are available for the patients that come in as well. Next slide, please. And so some of the strategies that have helped us with our linkage, I have listed here. So first is the co-localization of HCV services. So we co-localize our screening to places that are highly utilized by our patients. So that can be homeless shelters, that could be places that have Medicaid-assisted treatment or residential facilities. Another is hugely our street medicine program, which enables us to go to where the patients are. Not only are we having patients come into our clinic, we have the street medicine teams that engage with the patients in their houses. We make home visits. We have partner organizations like the People Concerned that we work with to give both housing and HCV treatment services to our patients. And we have consistent testing events. We test every week, multiple times per week, and we use our mobile van as well as our street medicine teams to engage patients with those testing. Next slide, please. And so I just wanted to highlight a few of the resources that we use as well. So for online database resources, especially when we're trying to find patients that we haven't been able to find for some time, there is HMIS Clarity. So that requires a one-day training, but after that, you'll be able to access that. And Lanes as well is, so both of these are online resources that have patient information at the last visits. If they went to a different hospital, you can access all of that information through these databases, as well as just another thing that has been helpful is to give patients prepaid phones as well, especially for patients who are higher risk, to be able to provide those phones to have a reliable way of contacting them has been very helpful as well. Next slide, please. So these are just some examples of how we've gone to where the patients are. On the left, we have our mobile van in which we test our patients. And on the right is just an example of a street medicine encounter where you don't need a mobile van, you don't need all of this equipment, but just a medical backpack and desire to want to go and see them is all you need as well in those settings. Next slide, please. So just to give a little bit of the data for our screening. So these are the numbers of tests that we were able to do each month. And for the year of 2023, we were able to do 3,095 antibody tests. And among those, we had around 150 patients that were RNA positive. So that yields a positivity rate of around 5%. Next slide, please. And so among those patients that were positive, we were able to link 133 of them, which yields a linkage rate of around 89.3%. Next slide, please. So kind of to give a longer term screening statistic. So this is from December of 2020 all the way until the most recent March of 2024. We were able to complete 7,566 tests. And among those, we had 373 confirmed positives. And we were able to link 300 out of 348 patients. And that discrepancy is just patients that transitioned out of care and everything. So that yields a linkage rate of around 86.2%. Next slide, please. So out of the experiences that we've had, what have we found that works? So we found, as many people have indicated today, that scaling up screening and treatment to those areas that are highly utilized by patients is something that is very helpful. And also another thing that we found is bundling HCV treatments with other types of services is something that is very helpful as well. So we bundle our care with mental health, with social work, with dental services all in one place in our clinic. And so when patients come in for these other types of services, that gives us another opportunity for us as the care coordinator to engage and link with the patient. As well as giving the patients another incentive to come in to the clinic to receive treatment as well. So as I mentioned, dedicated care coordination, focused care coordination has been crucial to ensure that patients progress through each step of the care cascade and to provide them with resources and anything that they need to be successful in their treatment. And also universal screening through one-time HCV testing that's in both clinic and on the street has been very important as well. And HCV treatment at the primary care level. So we have currently 7 primary care treaters that are able to treat for HCV in our clinic and in the different satellite clinics that we have. So that has been extremely important to help that low barrier access for treatment for these patients. And so also we have found that these questions are some that have been helpful to ensure that the patients are set up for success for the treatment. So are they motivated? Do the patients want to be treated? And are we able to be patient and have that patients to wait for our patients so that they can be treated when they are ready? Second is accessibility. So is HCV treatment easily accessible? Is it in the primary care level that we can provide that kind of treatment? And do the patients feel safe? Do they have a safe place to store their medications? And for us, that has meant providing medication lockers for the patients to be able to put their medication in a place that is safe, that they can access. Support. Does the patient have a support system? And do they have even a case manager that may be able to be a support system for them as well? And do they have contact? Those prepaid phones are definitely important in this aspect as well, where we have that reliable way to contact our patients. Next slide, please. So what more is needed? So further focus patient navigation. So if we were able to have care coordinators specific for hepatitis C on the county level or in different areas where hepatitis C treatment is given, that would greatly elevate the success rate and the amount of patients that we are able to see and treat. So that is something that is highly recommended. Another is creative screening strategies. If we were to have rapid RNA tests on the field, that would eliminate one more step that the patient needs to take in order to receive their treatment. Next slide, please. And so, yeah, I just want to acknowledge my team, my supervisor, Shannon Fernando, as well as here's my contact information. I am transitioning out of my role. The new point person who's taking over my role, her name is going to be Frida, and that's her contact right there. So if you need us to refer patients or link patients or anything, we are happy to help as well. So thank you so much.
Thank you very much, Joshua. A great program. It's just, thank all the speakers for sharing their experiences. We have, fortunately, we have, a good bit of time for some questions and discussion. So please, continue to submit those questions to the Q&A section. I did want to begin with a question that was submitted earlier, and I'll just go around the horn for each of you to touch on this. I think one of the questions I have, after I raise the questions that are in the Q&A currently, is just, hearing from others, doing the work that you're doing, what really resonates to you, just to reaffirm a strategy that's been found helpful elsewhere that's helpful for you already, or were there some innovative strategies that popped up that you find, of interest that it could be implemented in your area? But one of the first questions was regarding who is paying, what's the source of support for testing, in particular, the cost of treatment for these populations. And then secondly, what are the strategies for adherence to treatment, for this population, which is often mobile or is not always in the same place for a variety of reasons. So those adherence strategies, some of those we heard from, but just want to, go around and talk about, hear about the support for cost of testing and treatment, and to call out particular strategies that promote adherence. And I'll just start with Joshua, just to get us going from LA. Thank you.
Sure. Yeah. So in terms of cost for treatment the ways in which we have received funding, we have received federal funding. We've also applied for grants as well. And we work with the Department of Public Health, both the LA Department of Public Health as well as the California Department of Public Health, in order to help us funding. They provide the rapid tests that we use as well. So those are the different types of grant funding and different partner organizations that we work with.
Okay. And any particular key strategies for promoting adherence? It's very impressive, the high percentage of people you're getting into care. Yeah, for promoting adherence, I would say definitely waiting for the patient to be ready for their treatment, because the best time for the patient is the best time to start treatment. And so waiting until they're ready to be able to adhere. And also, I guess, emphasizing again that care coordination role of helping patients through their treatment has been very important for adherence as well. Elaine, please.
Hi, yes, thank you. So I think with us, the funding has been predominantly through research projects and some of the HIV leftover funding, if I can call it that, for a lack of better words. So a sub portion of HIV budgets, which is often still international donors. But I do believe we are moving towards domestic funding for some high-risk populations. And then in terms of adherence, I think I did mention a few things in terms of our drop-in centers. What I can add would be really to make sure the patients are enrolled in other services as well, not just hepatitis C, so the integrated approach. And for our linkage to care, when patients require to go to hospital, we also make use of what we call a health passport. So patient health document that becomes the identity document, as a lot of the individuals are undocumented as well.
Thank you. Mandana?
Yes, thank you for that question. I think there were also the issue of adherence to medication, as you mentioned, John, that came up as well. So the cost, we wanted to ensure that this was a sustainable process, and we work within the system that we live in order to be able to provide patients access to these treatments. So that was through government insurance, whether it be Medicaid or with some cases, patients were veterans, so they had Veterans Affairs health care system linkages. And additionally, when there was no such sources, we went ahead and applied for the patient assistance programs with the drug companies that provide hepatitis C directly. And everybody was a candidate based on lack of access through other means. So we were able to provide those treatments in such a way, and also set up services within the shelters themselves so that process became facilitated. The issue about medication adherence was really important, and thank you, Tiffany, for that question. This came up numerous times when we looked at actual complete adherence to medications, whether it be all doses of drugs. We were looking at less than 40% with patient report and provider report. When we looked at full duration of adherence, we were looking at less than 50% or around 50% adherence. But if you're looking at majority, sort of at least 80% of doses and duration, we got somewhere around the numbers that I shared with you earlier, about 80-some% from a patient perspective and less so from the provider perspective. I think what the main concerns here were about how the medications were kept and stored. And I think there were many, and the fear about sort of these very expensive medications being on persons and not being accessible to the clients. So we provided lockers and locks for those lockers within the shelters if patients wanted to keep them within the shelter. We did the direct observed therapy if needed when there was no possibility of doing so. And I'd also worked with, other means in which we could keep medication safe within the shelter system. And it was also existing for other types of treatments as well. I also provided the link to our publication for additional specific information. Needless to say, shorter duration of treatment had higher adherence, longer duration of treatment had lower adherence, as it would be expected. Thank you.
Thank you so much. Bernadette, Doug, please.
Amazing. So I think it's really interesting. We can talk about like population level interventions, but I think we always have to remember the individual, and that individual need assessments drive good care, right? So when we're talking about adherence for individuals, a lot of it is dependent on exactly what that person is telling us they need, right? So if somebody wants to do daily dispense, we can do daily dispense at a pharmacy. If somebody wants a week of medication at a time, a week of medication at a time is what we do. If it's a month at a time, then that's all right as well. Part of what we end up talking about is that people can just always come back. If something happens, come back to us and we'll figure it out, right? So I think a lot of times when people are told that adherence has to be as close to 100% as possible for treatment success, people end up having a slip up and then they don't come back because they feel like, oh, well, I messed it up and what's the point of even reconnecting? So really it's about like that open door policy of always bringing people back in. Doug is also really great at finding people in the community, rides an e-bike around downtown Toronto on a regular basis. So people that we don't think that we are going to be able to find again, Doug's like, oh,
we find them.
Yeah, exactly. So also being linked into correctional services in shelters, all of that kind of stuff helps. When we're talking about funding for medication in Ontario, as well as for the Ontario Hepatitis C treatment teams, we're really lucky the Provincial Ministry of Health has funded Ontario treatment teams. So that's these multidisciplinary teams that are embedded in different places within the province, and that's ongoing funding that we're able to get. For medication coverage, for people who are on social assistance, it's automatically covered through the Ontario Drug Benefits Program, so people can access medication that way. If people aren't on social assistance, there's private insurance that can pay Trillium drug benefits, which allow people who are lower income to have a deductible that is based on their income, so drug costs can be affordable. And then we also use pharmaceutical compassionate or patient assistant programs to pay for some individuals. Sometimes we have people who have no status at all, and then oftentimes it's compassionate access through pharmaceutical programs. One of the things that we ended up finding, we did a research study on hepatitis C antibody testing, where we gave antibody tests to folks with lived experience in the community, and they went out and tested a bunch of people. And we saw that there was good uptake for testing, but really poor linkage to care. So we've shifted our focus from testing being the thing to focusing on the linkage to care. So we now use treatment navigators, people who are connected to an individual and follow them through on treatment. Somebody who's had experience of going through hepatitis C treatment is embedded in the community, doing the work alongside somebody, as opposed to a treatment navigator or somebody who's further removed from that. So we pair people up to have somebody who's able to go through the entire process with them, which has been really successful. And actually at this point in time, we haven't had any treatment failures that we haven't been able to retreat and cure of hepatitis C. And that's in the lifetime of the program, which is, pretty remarkable given the level of complexity and instability that a lot of people end up experiencing who we work with.
Yeah. And to that latter point, I want to turn to Mandana for a moment, because it caught my eye that of those that were being found HCV antibody positive, in your sites, a high percentage had been tested previously. And so I wondered, does that reflect poor linkages to care previously? What do you think, what was your program providing that wasn't available to those populations that had already been tested and found to have been infected with HCV before?
No, absolutely. Thank you for that really important question. I think there was, this is a little bit of a skewed situation in that there has been a tremendous amount of efforts within the city of San Francisco in promoting testing. And as I shared with you, we have this End Hep C campaign, which involves multiple community organizations, healthcare services, and other entities in order to promote testing. And while testing was conducted, I think that the next steps of confirmations of infection, so active infection, and then also linkage to treatment were essentially where the drop-off had happened with ensuring that the patients go through the whole cascade of treatment. And so this is where, I think our focus on the next steps of confirmation and treatment was really important. And I also highlighted that, the importance of testing is ineffective if the next steps are not followed in HCV elimination. So that was quite eye-opening for us.
Thank you. Josh, there was a question about your database, about the homeless, a database that collects medical information. That's really, quite impressive. Data is really good data. It's hard to come by for HCV incidence, prevalence, and mortality overall, particularly for our marginalized population for homeless. So it's really, very exciting to see that that's being supported by the LA County, apparently. So I just think there were some questions about, is that indeed, supported by LA County? How well is it being supported? How is it linked to overall disease surveillance for hepatitis C, please?
Right, yeah. So yeah, the database is managed by the LA Homeless Services Authority. And so whatever information and data that they have, they put it into that database that is available for people to use. And so it has all sorts of information from patient visits to different hospitals. I believe the particular question someone asked was whether a person is incarcerated. So I believe it does have that information as well. And so, yeah, there is a wealth of information that is there at your disposal. So I definitely recommend using that database.
Yeah. Lane, there was a question about the availability of sofosbuvir, the cladosphere. I think, in South Africa, I think you touched on it, but just to give you an opportunity to reaffirm that it's now, nationally approved, drug combination that that's available, now rather than just coming in, through some, non-governmental organization processes alone. So if you could comment on that, please.
Yes, so our program was actually implemented prior to that, so we had to do bulk importing, lots of paperwork. But Soval from the and Soflidipizivir from the originator company is available, so no generics yet. And yes, in our state facilities, it's still at tertiary level, not at primary level. So in the private sector is where you would find it, more at lower levels of care.
Thank you. Mandana, and the other aspect that caught my eye was you mentioning in your sort of focus groups or formative research, you touched on financial incentives, and not just for incentives for the patient or for the client, if you will. We've touched on that, but also for the system or for care providers, and we've touched on support for treatment. But what are the important financial incentives to keep in mind for the delivery, of these services, by clinical care providers that are seeking to provide an array of services? How do you get hepatitis C on that agenda? You have any thoughts about that, please?
Sure. Thank you for that important question. We didn't specifically get financial incentive as a facilitator from a provider perspective. It was more directed towards patients in having them engage in care. But you're absolutely correct in that there has to be resources devoted to implementing the infrastructure that is needed to address this, and identifying sort of hepatitis C care coordinator individuals, for example, which was a key facilitator that was brought up by these questions that we asked the key stakeholders, to be able to sort of address some competing priorities of these individuals or providers, and addressing many other potential comorbidities within this population requires financial support. So I think from a big picture perspective, showing that these efforts work, and showing that it can be implemented despite suboptimal duration of treatment or adherence to treatment, and the really high cure rates that can be accomplished, it is important to be thoughtful about how to divert those resources from a systems perspective to these efforts.
We only have a few more moments. I did want to go around and just to hear from everyone in two ways. Do you both have very effective programs, but are those programs sufficiently resourced to meet the needs of all the homeless in your communities, or do you really need a great expansion of that? You just can comment on that, please. And then as I go around, if you just could comment to, like I mentioned earlier, to reaffirm any strategies that you heard from others on the call, or some novel strategies that could be brought into your program for consideration going forward. So again, I'll start with Joshua and then work back from there. Yeah, Joshua, any thoughts on that, please?
Yeah, absolutely. So I would say, so we could you repeat the question again?
Do you think your program, your effective program, is large enough to meet the needs of homeless in Los Angeles, or needs to be greatly expanded?
Yeah, I would say, especially in the Skid Row community and the greater LA area, there is a huge need to address homelessness. So I would say we need all the help we can get. We have so many partner organizations that we do work with in order to help address the needs of those in our communities, but constantly needing more people that are motivated to help and who want to help. Not only in our organization, but also in the different organizations that we work with. We always hear greater needs for staff and for people who desire to help. So I would say definitely that is something that is very big. And yeah, I just wanted to reaffirm everyone else, the things that they talked about are some of the things I noticed are things that we tried to implement as well, as like incentives and really waiting for patients to be ready and thinking of the patient first and foremost. Those are all things that I really wanted to reaffirm in everyone else's program as well.
Thank you so much. Elaine, your thoughts, please?
Yes, thank you. So I think what we've done is a drop in the ocean. We're one of two, we 2 of 16 harm reduction sites in the city, and then I'm not even talking of other major cities in the country being affected. So our aim was really to pilot and to show that it can and should be done at community level, but we really hope that it would be scaled through more resources. And then just listening to the other presentations, I appreciated the role of the HCV care coordinator, and I think that's really a space where we have to move into, especially wanting to superimpose it onto our HIV programs that are existing. So that would be very important for us to explore. Thank you.
Thank you so much. Mandana, please.
Thank you. I just wanted to share that thanks to your effort, John, as well as the others within the field, and the focus on policies currently in really testing for hepatitis C in a universal fashion and importance of hepatitis C elimination. This is at the forefront of the care of our vulnerable patient population. And I think that it is important to note that while we showed one particular model of care delivery that works in meeting the patient, the population or patients that are where they are. In this case was the shelter themselves. There's been a tremendous amount of efforts that have now been initiated and have been as well previously in place with regards to meeting patients where they're at, meaning whether it's mobile entities, whether it is really expansion of services within the safety net populations, and also obviously the amazing VA model that shows how to do this the right way in those areas. So I think this is just, again, a very much of an effort that needs to garner still partnerships and continue to expand, but thinking more in novel ways is going to be important.
Bernadette and Doug, please.
Expanding testing so we can do treatment. And I also think hiring people with lived experience is a great opportunity.
We find that we can't test 300,000 people ourselves, but we're happy to end up connecting those folks to treatment. So universal testing for everybody, embedded in primary care, in emergency departments. Let's get testing more universally done, and then we're happy to end up treating anybody.
Opt-in, not out.
Thank you. Thank you so much. Excellent overview of your programs that are really reaching this population where otherwise they would not have access to these services. So thank you again very much for your efforts to achieve health equity for these populations. Again, all of this information will be available on our website at globalhep.org. The presentations, the videos of individual presentations, as well as a summary to touch on the highlights from these different presentations. And also, please sign up to our newsletter while you're at globalhep.org so you can keep abreast of the webinars coming up, and how you can get involved in other coalition projects and programs and educational efforts. Thank you again for all of your interest and work to achieve goals for hepatitis elimination around the world. Take care. Thank you.